As we're looking at chapter 7, one of the most important things you're ever going to take care of is the airway. It is so absolutely critical that we can manage an airway on our patient. They obviously need that in order to survive, because without breathing, you're not going to make it. And we need to kind of do a little review of some anatomy of the airway and how to open the airway. A device that you're going to learn once we're able to do skills is something called an oral pharyngeal airway, and it's a thing you actually put in the person's airway to keep it open when they're not conscious. And we'll talk a little bit about breathing and ventilating and those sorts of things. So it is the most important skill that you're going to do. It's just absolutely critical because your brain is so sensitive to the lack of oxygen. We can't stay alive. So to survive, you have to be breathing deep enough, and you have to have the right rate of breathing. If you're not breathing, things are going to go bad really fast. So there are some times actually where we're going to put all of our time into just managing airway and breathing. We might not get to any of other parts of our assessment because we're working on the airway and breathing kinds of things. And that becomes really the priority. It can be easy to look at other things because, like, an injury really can catch your attention, but if you're not paying attention to the importance of breathing, we don't want to take that for granted. So as we look at the airway, there's upper airway and lower airway. We're kind of looking at all the upper airway here. So you have your nasal pharynx, oropharynx, and laryngopharynx. And as we look at those, they're all part of your throat, if you will, but it's the nasal part, oral part, and laryngo. So it's like where your larynx is, your mouth, and your nose cavity. And a lot of times people think your nasal cavity is only as big as you can stick your finger when you're picking your nose, but actually it's over the entire top of the roof of your mouth. And we mentioned that maybe in anatomy. It was super cold out, breathing in through your nose, actually, like if you're running or doing outdoor activities, that actually gives it a chance to warm the air a little bit, as opposed to breathing into your mouth. So it's a good little technique there. And we have the at the back of the throat. So this is the tongue here, and the tongue's not that thick. This is kind of like, there's the thickness of the tongue right there, and that's the underneath where your tongue hooks up. But the back, you have the epiglottis, and then we have where the vocal cords are, goes into the trachea. So just remembering what that looks like is important as what we're managing. The other thing to know is as you're breathing, your muscles help you with your breathing. So your intercostal muscles, they are active. That's the in between your rib muscles, plus your diaphragm. Now the diaphragm, when it contracts, it moves downward, and that changes the volume in your chest. And the whole reason breathing works is a change in volume of your chest, in particular, is with that diaphragm moving. So when you breathe in, it's contracting, and when you exhale, it's relaxing, and that changes the pressure. Pressure then wants to go into equalize, because it always is like that little fourth grader. That's not fair. It wants everything to be equal. If you live with a fourth grader, you know what I mean. For some reason, at fourth grade, that's what are not fair. And then we get into the alveoli and the exchange of oxygen and carbon dioxide. We kind of know that because we've gone over it. Worth noting the difference between adults and children with their airways, that in proportion to what's going on, the tongue is larger in a child, takes up some more space in their mouth because their airway passageways are smaller. Epiglottis has kind of got a U shape to it, protrudes into the pharynx, into the throat a little bit. Less rigid and developed, the cricoid cartilage around your trachea. So it's narrower, softer, it's more flexible. So overextending the head could be a concern with the airway management. It's just also as the airway starts swelling or the tongue starts swelling, because the airway is smaller in a child, there's less space to swell. The tongue is bigger, can be more of an obstruction. Those are a few things just to be aware of there. Chest muscles, when you're having trouble breathing, a lot of things can cause it. It can be from an obstruction. It could be that you're having trouble with the contraction of those muscles. Let's say somebody gets a spinal injury. One of the major concerns with spinal is that their muscles aren't able to move, and you need your diaphragm to move, you need your chest muscles to move. So what happens to a person when they get a high up spinal cord injury? They end up on a respirator because the messages sent from their brain are not going to their muscles, and that's a problem. They're going to die. So if you had a spinal injured patient, they might not be breathing because there's no messages going to their muscles. And then all of a sudden you are their life support until you get them in. Could also be breathing problems where the breathing is too shallow, or it's too fast or too shallow. Here's kind of the rates that we look at an average adult. For you, I'm going to call you all average and adults, is 12 to 20 breaths per minute. And we did some vitals before we were sequestered here. You had a chance to count respirations. That's something you can do on another person, but you really kind of want to make sure that they're not paying attention when you do it, because otherwise they get a little self-conscious and don't breathe at the same rate. Children and infants are a little bit higher in their respiratory rates, as you can see, because they're tinier, their lungs are smaller, and they're trying to keep things going. Here we can definitely see this person is having trouble breathing. As you look at her posture, these are some real classic signs of somebody having trouble breathing. Her eyes are open because she's kind of scared or like having difficulty sitting a little bit forward. They call it a tripod position. And your review quiz 1 and 2 talks about this, by the way. There's a word here I just want to explain. It's called patency. Patency means open. So your airway is patent. Sometimes people think it's patent. I'm pretty sure it's patent, but let's not get in a fight. Tomato. Just realize we're not talking about like that your airway has a copyright, which is a patent. A patent, it just means it's open. And we got to make sure airway's open. That's our priority. Cyanosis is coloration, that bluish coloration that you can get around nail beds, lips, depending on skin tone. You can notice a little bit in the cheeks sometimes, palms of hands. That you can notice those. Respiratory distress. That's something that'll be handled in review quiz question 8. But when you look at a person in distress, like when are they having trouble? We might hear noisy breathing. So that could be a gurgling, wheezing sound. Stridor is like a higher upper airway something caught in there, like like that. And it's more of like something stuck in the upper airway when we look at that. Wheezing and gurgling. Gurgling tends to be, that made me cough. Gurgling tends to be like fluid in the back of the throat, where wheezing is lower into the lungs. So, that sound, at first you just hear noisy. That's what you need to know. It's noisy. That doesn't seem normal. But then the type of noise sometimes makes a difference too. Another thing is something accessory muscle use called retractions. And that's where the muscles pull, or the skin pulls in on the ribs. I will show you a video of retraction. I got to find it. I don't have it right now. But I will show you that so you can see what it looks like. Also, anxiety or restlessness. If you can't catch your breath, oh my gosh, do you get anxious and restless? The similar types of feelings you get when you have claustrophobia. Poor skin condition, that it might have poor circulation, for example. Or another thing is if you see trauma to the chest, that's going to tell you that there's a problem going on. So use your senses to evaluate the airway. So looking around the scene, here you can kind of see an example of some hypoxia of the cyanosis of the lips, or like kind of the ends of fingers. You can see that's going on there. Rise and fall of the chest is obviously the easiest. Also, if they could get kind of confused. So once we know how to kind of assess an airway, how do we open it? Now, opening the airway, you learn this in CPR, head, tilt, chin lift. That's the simple way to do that on a non-spinal injured person. If they have a spinal injury, then we want to use the jaw thrust maneuver. And the jaw thrust maneuver is you're putting your thumbs on the cheekbones, and then you are going under the jaw and you're pushing it forward. You'll also suction an airway if you need to. And the thing about suction, I have to explain to you, is your suction that you use in your house, sometimes you have like multiple types of vacuum cleaners. And in my house, I have, a regular one. And then I have one called a shop vac. And if you've ever seen a shop vac's just like this canister, almost like R2D2 with a hose coming out of it. And it's good in like the garage or the shop, or like if you've ever gone to the gas station and you pay for like the vacuum to suction out of the car, you can suck anything up with that. As long as it fits in the hose, you can suck it up. I mean, you could suck up a whole bag of dog food. Some of them you can even suck up water. Okay, but chunks, like as long as it doesn't plug the hose, you can suck up those chunks, right? If you use your normal home vacuum cleaner, it is going to, like, if you ever vacuumed up a sock with a regular vacuum before, goes, it's just not good. Well, suction is really only for the liquid in the airway. It's not for the chunks. So it's the wimpy vacuum, not the good vacuum. And there are electric suction machines that create suction with kind of a little compressor. And then there's handheld suction with like a thing that you squeeze. And we'll see a picture of one of those. They're only for the liquids, the big chunks. So someone barfs up a burrito or bratwurst or pizza or whatever their stomach contents were. You want to scoop out the chunks with a gloved finger. Okay. And then you suction just the liquids. Otherwise, you're going to plug up the hose and it's not going to work. It's kind of early in the morning to talk about puking. Kind of gross. Now, to keep an airway open, we have these things called oropharyngeal airways. And they're going to go from, basically, they go in the mouth, and you'll see them from the side of the mouth right to about there. And it just sits on the back of the throat, or between the tongue and the back of the throat to keep the airway open. This is an example of how it's done. It's only done on an unconscious patient without a gag reflex. So that tends to be an unresponsive patient. And what we do is we measure it, first of all, because there's all different sizes. And you go from the angle of the jaw to, like from the corner of the mouth to the angle of the jaw is what they say. Corner of mouth to angle of jaw, or else corner of mouth to tip of ear, when you measure that. Then if a patient has a gag reflex, so they're not 100% out, but they're having trouble keeping their airway open, then they'll use a nasal pharyngeal airway. And a nasal pharyngeal airway goes right in the nose, actually. You can put a water-based lubricating jelly on there. Really important, never use anything besides water-based, because petroleum, like Vaseline, that is going to react with oxygen in a bad way. So you don't want that because it can be combustible. The other thing is, if you've ever seen like when oil hits water, how it spreads. Well, petroleum jelly has, or like petroleum jelly is the other name for Vaseline. It's a petroleum product, so it spreads on the airway like that. You don't want that. So you want a water-based, like Surgilube is what they call it. And that's a sterile lubricant that's water-based. That would go on the nasal airway, then it goes in the nostril and down the throat, basically. So here you can see, does that look uncomfortable? There were a few times when I had the National Guard come and speak in class, and one of the soldiers would have his fellow soldier lay on the table and put the nasal airway in him. That's always fun to watch. But this is on a person, if they have a gag reflex, you can still keep their airway open. The contraindication, meaning a reason why you would not do this, is if they potentially have a skull fracture. If you think they have a basal skull fracture, we don't want to do that. That means the back of the skull. As with a skull fracture, it could actually go into the airway. We don't want that. I was on an ambulance ride along one time, and we got called to a person that was in respiratory distress. Right away, you could tell he was in respiratory distress because it almost sounded like he was gargling in phlegm and mucus in the back of his throat. I felt super bad for him. He was quadriplegic, so he was in a wheelchair, couldn't use his arms or legs. That meant he didn't have his accessory muscles helping him breathe or helping him cough. And so he had a really bad respiratory ailment, and he ended up needing to be suctioned as we were going to take him to the hospital. And to keep his airway open, to put a nasal airway in him to suction him out. So that was a time where he was wide awake and had a nasal airway. Most of the time, they're not quite awake, but that was an instance where that happened. So as we're assessing, again, looking at the person, I like in this picture, he's kind of getting down to the guy's level as he's talking. He's not towering above him, but he's doing an assessment. He'll look at mental, how is his mental acuity, as well as looking in his eyes, checking his breathing. Here we can see the guy looks like he's having some discomfort and difficulty. So are they breathing adequately is a question you have to ask. And if you can't speak sentences without difficulty, for example, does that seem adequate? Or you get to a call and someone's on the ground not responding. It's slow and shallow. There's gurgling sounds. They're very pale in color. Does that seem adequate? No. Two different things. One, someone's wide awake, but they can't get out sentences. That means they're having trouble. Or somebody, they're breathing, but it's gurgling. That's not good. So you see, you could have all sorts of different presentations of the patient, but the question you have to ask is, how deep are they breathing? Are there any sounds that are not proper there? Is their brain working? Remember, the brain, if someone's awake, is one of the best indicators of how they're doing. Likewise, if they're not awake, that's telling you that things aren't good. So that mental status is one of the fastest indicators of what's going on inside someone's brain if they're getting enough oxygen. Also, you'll find that either the pulse might go higher or lower, breathing might go higher or lower. The rate might be off. So that's another thing you look at with breathing. An overdose patient is going to breathe, and eventually they slow down and stop breathing, like opiate overdose type of a thing. Also, chest movement you look for, and how hard are they working to move? Are they breathing like I'm breathing, where you don't see much, or are they like with the accessory muscle use? That makes a difference. So if we have to, we'll give the person oxygen, a supplemental oxygen. And if it's like a trauma or a difficulty breathing, you can give them high flow oxygen using what's called a non-rebreather mask. That bag on there allows oxygen to be delivered, and it brings in oxygen so that when you breathe in, it's fully oxygen, not mixing with room air. Another thing we have is something called a pulse oximeter. This one's gigantic. We have small ones the size of what fits on your finger now. And actually, with this whole COVID business, one of the things they look for when someone has COVID is they're going to check their pulse oximetry, and they might be having a perfectly fine breathing rate, but they look at their oximetry and it's really low, meaning the oxygen content in their bloodstream. And that becomes like, ooh, you got to get in type of a thing. So 95 to 100 is our normal pulse oximetry. And between 90 and 95 is considered mild hypoxia. Hypo means low. Oxia, so hypoxia is low oxygen. Severe is anything below 90% that we look at there. So it's a one indicator, but it's not the only one we go by because it's not always 100% accurate. It can be based on if they have nail polish on, that's going to get in the way. If it's really cold, they might not get as good as circulation in their finger. So those are things that can get in the way. The other thing that's kind of could throw a person off is if they're exposed to carbon monoxide. It's going to show 100% oxygen, but it's because the carbon monoxide took the place on the hemoglobin of oxygen. So you have to put this in its place where this is a tool, but it's not the only reference we look at. We also have to look at what's their mental level, and are they seeming okay? If they're 100% oxygen, they should seem fine. And if they're not, use it that. So we use oxygen tanks, and there's different sizes. Most common that we use portable oxygen's D or E. This is D, the middle one, and E is the larger one. And then this one over here is a super D. This has the same amount of oxygen as this. It's just in a more compact package. And the the air in a tank is about 2,000 pounds per square inch. That would not be healthy for your lungs. So you put a regulator on it, and a regulator brings and knocks down the pressure to about 40 to 50 pounds per square inch. You're still not directly putting it in the lungs, but you wouldn't want it coming out that fast or high. So with an oxygen tank, and eventually, my hope is we get in class so you can do this. I'll also make a video when I sneak into school to get an oxygen tank, or I'll just sneak in there and make the video because I don't really have room for one at home. And I'll just go over how to set a tank up so you can see that. But you open it, you put a regulator on, and that then allows you to adjust the flow meter. And then we have masks that we use. So a non-rebreather mask delivers oxygen at about 10 to 15 liters per minute of oxygen is what it delivers. And you put that mask on, and I had to write something down. Got a pretty neat video to show you about hypoxia. Masks, non-rebreather, 10 to 15 liters per minute, concentration upwards of 90% oxygen. This right here is not a non-rebreather mask. This is a Venturi mask. That's kind of a strange mask. We won't make a big deal about that one, but that one's adjustable, and it blends with room oxygen. So we deliver oxygen to patients. If they don't need high flow oxygen, let's say they're chronic obstructive pulmonary disease, they get supplemental oxygen because they have trouble. These are the kind of people sometimes you'd see at the grocery store or casino, or maybe if you know a grandparent that has it, that they're wearing oxygen, they carry it with them. This is between 2 and 6 liters per minute oxygen delivered. A person that's anxious, sometimes putting this on when they're having trouble with breathing, it helps them a little bit too. So that's a helpful thing. It just goes right in over the ears, and they don't feel claustrophobic or covered by it at all. So that's something that can be done. There's only time to ventilate a patient. Let's say we're using the bag mask device. We're using, sometimes it's called ambu bag. You squeeze it. We did that with CPR, if you remember. Well, they've got the oral airway in the guy's mouth. You can see it right there. And then with a pocket mask, it can be done right now. You would not do any ventilation with a pocket mask because of COVID. We would not want to take those risk of being exposed to particles. So you'd only use a bag mask device when you do that. But that's what it looks like. We've used a bag mask. I'll go over the parts of that again when I do a demo. But basically, you got the bag. It has a hose that hooks up to your oxygen tank. You hook it to 15 liters per minute, and then this bag fills with 100% oxygen. Each time I squeeze the bag, it sucks the air from this bag, which is 100% oxygen, and gives it to the person. Normally, right now, our air is 21% oxygen. If we put on a mask, we can deliver higher concentration, upwards of 95 to 100% oxygen if you use a bag mask device. But it has to be hooked up. Now, if you run out of oxygen, this just pulls in room air, which is still better than exhaled air. Exhaled air, you use about 5% of your oxygen. So when I breathe in, if I exhale and I measure that air, it's about 16% oxygen still. That's why mouth to mouth would work, or mouth to mask would work. But with a bag mask, you can give high flow oxygen with a good seal and get that air in without exposing you to airborne droplets, or like when they vomit, that it doesn't go in your mouth, because that'd be gross, wouldn't it? You don't want to get barfed in your mouth from someone else. Ugh. I don't like it anyway. Dog barf is bad enough, much less a human barfing in my mouth. So bag mask, you're 10 to 15 liters per minute of oxygen delivered with that. I typically just put it right at 15, and then you squeezing. You're doing one breath every 5 seconds as you do that. If they have a neck injury, we do use the jaw thrust, and that's how that goes. And there is something called cricoid pressure, otherwise known as the Selleck maneuver, where you could push down on the cricoid cartilage when you are ventilating a patient, and that keeps the air from going into their stomach, which could reduce the risk of vomiting. This one used as local protocol. Generally, we don't do cricoid pressure, but I at least want you to know it exists. One of the ways you can keep a person from being more likely to vomit is don't forcefully ventilate them when you're squeezing the bag. You don't want to squeeze it super hard. It's just a nice controlled squeeze as you do it, so you're not forcing that air to turbulently go into the stomach area. So that's what we look at. And when you're going to use a bag mask device, you could use it on a conscious patient who's not breathing adequately. You could assist them by putting it on and then coaching them and breathing and say, when I squeeze the bag, breathe with me. Ready? Breathe. Here we go. Breathe. You know, that could be a thing that you do. You'd have to talk them through it though, as they do it. It's really hard because they don't want this on their face, but it's something that could be done, just so you know it's out there. If they're not responsive, then they're laying on the ground, and that's not as big of a deal. You just kind of do it. But ideally, it's two people, one holding the mask, the other squeezing. Choking. Check out that guy. Looking good at the picnic. All of a sudden, he started choking. People don't always put their hand to their throat, but they could. We've learned about this, how to take care of it with abdominal compression thrusts, as well as what we look at is you either have someone who's got a mild obstruction where their body's going to clear it on their own, or else it's severe and they need your help. That's when we're going to take care of it. If they're too big to get your arms around, you can see you can actually do chest compressions when you do it. Instead of being on the abdomen, you could be way up high. Also on a pregnant person, because you don't want to put pressure on the uterus. If they're unresponsive, you can look in their airway, and if you see an object, you can sweep it out. You hold with one hand and you sweep with the other. You got to have gloved hands. Don't do this on someone who's awake. They will bite you. We don't want that. Here we could see in this picture, things aren't looking too good for this person, but they are kind of laying in a recovery position, which is good. So you want to move them to the floor because then you can get the airway opened well. This would actually be kind of like what you might find with a opiate overdose person. They're on the couch and all of a sudden they're out and you got to move quick, get them on the ground, start suction the airway, clear it. Somebody else is going to get Narcan ready to give them. Usually it's a nasal spray you can put in to counteract that opiate overdose. So that is our information about topic. Couple things here. Some terms: inhalation, exhalation, that's breathing in and out. Hypoxia, that's low oxygen content. Patent means open. Cyanosis is that blue coloration of the skin. Paradoxical motion, I didn't see that in the slides. It's in your textbook, so if you read the chapter, they'll talk about it. And this chapter, I recommend at least scanning and looking at the things, the medical terms and the objectives, and going over that. If you had a chance to pick up a book yesterday, that's great. I think I was able to tell you that before class was over, that it was available yesterday to pick up. It's also available tomorrow from 8 to 3. You can pick up a textbook at school, an EMR book. You always can use the digital book that I have here, like the scans, but if you want paper, it's there this Friday. That's tomorrow. Pick it up. And they'll go over like the med terms in there. But paradoxical motion is when I breathe in, when a patient breathes in, normally their chest should rise, but a part of it moves down when the other goes up. So it's kind of like a separate part. And that's because there's what's called a flail segment. And that means there's more than one part of the rib broken, and it moves independently. So that could be a problem. Respiration is then breathing. Accessory muscle use was where you can see them moving muscles as they breathe, where retractions is like I can retract my neck. See how it pulls in. That would be retractions. And that's a very unflattering angle. I'm going to have to sneak down here now. Now you can just see my hair and eyebrows. Okay, that's less unflattering at the moment. Pulse oximeter is the device that reads your pulse oximetry. Eh, nothing else really too big there. All right. So that is my main information for today that I had to cover for you. Take a look at your review quiz as well as your worksheet. I always recommend looking at the chapter and glancing through it. And it has helpful material in there. Otherwise, it should be good.